All right, hello and welcome. I know that we have a number of folks who are still joining us, but in the interest of time, I do want to get started. So this is Trace Modeling Robust Containment Policy in the Face of Uncertainty with Ross Hammond. I want to give a quick introduction to Ross. As many of you know, Ross is external faculty here at SFI. He holds other academic appointments at Washington University in St. Louis and the Harvard School of Public Health. He's also a senior fellow at the Brookings Institute, where he directs the Center on Social Dynamics and Policy. Ross is a member of the National Institute on Minority Health and Health Disparities Advisory Council. He serves as a public health advisor for the National Cancer Institute. He's a commissioner for the Lancet Commission on Obesity and a member of the National Academy of Science's Food and Nutrition Board. He also serves as a government advisor to the FDA's Center for Tobacco Products. I'm really excited that Ross is having this conversation with us today. There are many methodological approaches that have grown out of SFI and complexity science more generally, but agent-based modeling really stands out for embodying the philosophical orientation that underlies complexity thinking. If you remember the tutorial at last Action Symposium with Bill Rand really focused on the sort of how you do agent-based modeling and where it's going. Agent-based modeling had a lot of early successes in specific vehicle traffic management stands out in particular. Where I think agent-based modeling has gotten itself into trouble is in cases where models require many behavioral assumptions and inputs, and in particular situations where we don't have a lot of hard empirical data to calibrate those operational parameters and those behavioral assumptions. As a result, there are many important domains that could benefit from the agent-based modeling approach, but where agent-based models have nonetheless failed to make an impact as of yet. The TRACE project and Ross's work more generally really stands out as doing a uniquely great job of handling this uncertainty around agent-based models, parameters, and assumptions. The project that Ross is describing today applies this sort of more robust way of dealing with the parameterization problem to one of our most pressing policy issues. And so it is with much excitement and thanks that I'm going to turn it over to Ross.
Great, thank you very much. I'm pleased to be here. Okay, so I'll try to talk for about half an hour, explain the TRACE model, why I approached it this way, what some of the key findings are, and how you can learn more, and then leave the second half hour for questions and discussion. So if you could mostly hold your questions till the end or put them in the chat, we'll take care of sort of triaging Q&A in the second half. Before I begin, I just do need to quickly say that all the affiliations Will mentioned should not be construed as representing any official opinions in what I say today. The opinions expressed are my own and should not be construed as being official in any way. So as many of you know, background in the US situation that's motivating this work is that there's continued high heterogeneity among states and localities in the timing and speed with which they are releasing or not releasing social distancing restrictions and businesses restrictions. There's huge heterogeneity in the amount of capacity they have to do testing, contact tracing, and quarantine. And there's huge heterogeneity in the prevalence and trends across the United States. In general, there's widespread concern about the dangers of reopening, but a lot of pressure to reopen due to the economic costs and social costs associated with continued closures of things like schools and businesses, all of which makes there an urgent policy need for middle path strategies that allow you to mostly reopen while containing the epidemic. In addition, we have many key uncertainties about COVID itself and the underlying biology and epidemiology, which make policy choices particularly difficult. They include questions about how much asymptomatic spread is really going on, what the risk both of adverse consequences and of spread is among children, how much immunity is conferred by having survived COVID or from a vaccine, and what kinds of risk factors might be at work in determining who gets really sick from COVID and who has no symptoms at all. And given all these uncertainties, I think the policy discussion in the US has tended to center around either a totally surveillance-driven repeated opening and closing cycle where you try to reopen things and then if cases mount, you close them again quickly, or a testing and tracing approach to try to substitute for mass social distancing. And we know from other countries that widespread testing and contact tracing can be quite effective in containing outbreaks after the initial wave has sufficiently passed. But as we try to think about how to do testing and tracing, which is really the focus of our model TRACE here in the US, immediately lots of pretty concrete quantitative questions arise. How many tests do you really need? And if you read the media, you'll see widely varying estimates from we need to test every American every day to we already have plenty of tests and everything in between. How accurate do the tests need to be? What is the most efficient way to use limited testing? If we're not testing every American, who then are we testing? What is an appropriate way to use serological tests? On contact tracing, we need to know also how much capacity we need to do contact tracing. When we successfully trace contacts, what is the right quarantine protocol? And how important and realistic will adherence to quarantine really be? And we need to know if we have enough tests and they're good enough and we have enough contact tracing capacity, does that mean we can in fact open schools safely and open businesses safely? And if not, what combinations of policies do we need to keep control over the spread of COVID? All of this will be complicated further when influenza starts to spread in the coming months. And ultimately, the right answers to all of these specific questions depend in important ways on these still uncertain assumptions about the underlying epidemiology of COVID. So the TRACE model was designed to help policymakers manage all of those challenges that I just listed. TRACE stands for Testing Responses Through Agent-Based Computational Epidemiology. And it differs from many, many other existing models that you've seen and heard about in the news and in your own explorations of the COVID space in three important ways. The first is it is not a forecasting model. It is not intended to be a forecasting model. Instead, it really sees itself as a policy laboratory in which you can explore a very wide range of different formulations of policies around this general theme of testing and tracing, different concrete answers to all those questions that I said earlier, and see how they fare. Over 10,000 different combinations are explored. The second is that many, many models out there take essentially a best guess estimate for what are still very uncertain parameters, and maybe do a little bit of sensitivity analysis around those parameters. But in general, their results depend on the set of parameters that they chose. And we actually went the other direction, given all this uncertainty, to really embrace the uncertainty, to sweep huge ranges of parameter space over many dimensions, to find policies that are robust so that if we don't know what the right answer is, we still can be sure that the policy we're using does the best possible that's available to us. So we systematically covary things like asymptomatic transmission and the incubation period of the disease and the underlying reproductive number of the disease and adherence to quarantine and all sorts of other assumptions. So all in all, we actually explore 165,000 different scenarios over 3 million simulations. And the third is that this is an agent-based model, as Will alluded to earlier. And one of the reasons that that's important and that has been important in the history of modeling infectious disease, particularly over the last decade, is that agent-based models allow inclusion of substantial heterogeneity. And we know that this kind of heterogeneity is really important for COVID, maybe even more so than things like flu. Agent-based computational models have been widely used throughout the infectious disease modeling community. I myself was part for many years of a large distributed NIH-funded network called the MIDAS study, Models of Infectious Disease Agent Study, which used a lot of agent-based models and had a lot of policy impact, including doing daily simulation advisory runs for BARDA, the federal agency responding to the H1N1 pandemic about a decade ago. And some of those models that were developed at Brookings are shown here. One of the features we know is going on in COVID is heterogeneity. Not only does heterogeneity seem to matter by age, so on the left I'm showing you distributions of cases and fatality by age from Chinese data, but we also know that super spreading is going on in a really important way with COVID. By many estimates, in the 1918 flu pandemic, the magic dispersion factor number K, which says what percent of cases are due to what percent of transmission is due to what percent of cases, was as high as 1.0, and for COVID maybe as low as 0.1. And what that means is that about 80% of the spread might come from only 10% of the cases, and the remainder of the spread might come from another percent of cases, 10% of cases, so that 80% of people who get COVID don't pass it on to anyone. So it's a very unusual distribution of infectivity, and this kind of heterogeneity really matters too. Another thing we know really matters, given the age heterogeneity, is that the contact pattern, the structure of how we have contact with others, really matters for COVID in particular. What we've done in our model, which I'll go into in a little more detail, is use empirically driven contact matrices that are age by age. So in these matrices, 5-year-olds have much more contact with other 5-year-olds than they have with 50-year-olds, for example. And finally, we know that asymptomatic transmission is a big problem, and that is actually uncertain how much of it is going on, and there may be heterogeneity across settings in how much is going on. So how does TRACE work? It is an agent-based model with a population of agents demographically representative of the United States. Activity patterns are driven by age and categorized across 4 settings. It is a so-called SEIR model in which people start healthy. In a susceptible state, they are exposed, and then some of them will transition directly to being symptomatic. Some of them will transition to a pre-symptomatic state where they're still contagious but do not have symptoms yet, although they go on to have them. And some of them will enter an asymptomatic state where they are infectious to others, possibly not as infectious to others. That's one of the sensitivities we explore, but they have no symptoms. And then they all return to a state called R, which can be recovered or removed. And the infectivity distributions that I talked about earlier are done both across individuals and across disease state. We then have a stochastic heterogeneous contact network assigned to agents. And so agents have different sets of contacts at work, at school, at home, and in the general world around them. And these are empirically informed by age contact density that I talked about earlier. There's lots of parameters in this model. They're all drawn from literature, and they're all varied over wide ranges. And I'm happy to go over these in more detail during the questions. What do we do with this model? We do a lot of policy simulation. So we first look at social distancing policies. We include schools, which can be open or closed. We can include workplaces, which can be open, partially closed, or fully closed. And we include the possibility of very heavy-handed shelter-in-place rules being in effect. Across the testing policy dimensions, we vary over a wide range the number of PCR tests a day, the sensitivity and specificity of those tests, the amount of contact tracing capacity, the targeting strategy for PCR tests, including a wide variety of different strategies, the quarantine protocol, the amount of adherence to quarantine, and contact tracing is modeled specifically as a total number of contacts you can trace in a day. And the reason that we approached it that way, rather than for example, a labor force perspective, is that this actually makes success rate endogenous. As there's more and more cases at the peak of an epidemic, the same amount of capacity quickly becomes overwhelmed and can't get to most of the cases that are reported, whereas at low periods of prevalence, then it's relatively easy to use the same amount of capacity to get most of the contacts. All the policy dimensions I mentioned are varied over wide ranges, often spanning several orders of magnitude. And our goal was to first capture potential synergies between policy elements. So for example, if you use limited testing more efficiently, then your tracing capacity will go further because you'll be generating mostly cases that actually do need to be traced and not as many that don't need to be traced. We secondly want to understand the substitutability of policy elements. So we want to know how many tests of what accuracy you have to have in order for it to be able, to be able to open schools without producing large epidemics. Or similarly, if you have low test accuracy, can you overcome that with a sheer volume of tests, for example? Those are all questions we looked at. We third want to understand multiple robust policy formulation. So we want to understand what mixtures of policy do well, even if you assume beyond the worst case that CDC has put out for what might be the assumptions for the underlying biology. And finally, we want to highlight what the most important data uncertainties are in order to make less demanding policies likely to perform well. So if we know nothing at all about the amount of asymptomatic spread, and we have to assume that it might be very high, then there's a fairly limited set of policies that work. If we could get some information so that we know it's above or below 50%, then there's a whole other set of policies, if we knew it was below 50%, that would also work well and that are much less demanding, that sort of thing. The two key outcome metrics that we look at are prevalence through time and the cumulative infections over the course of each simulation, but we also capture this contact dendrogram, who got this COVID from whom, under what circumstances. We keep track of the proportion of true cases that are missed by testing and the proportion of true contacts that are missed by limited tracing capacity. And we keep track of the level of disruption to normal individual activities, both economic and social activities that are going on, so we can understand how you can have the most efficient policies possible that maximize epidemiological control while minimizing disruption in society. So I have two sets of things to talk about. The first, briefly, will be some high-level general results to inform the broad policy discussion right now at a national level. And then I will talk a little bit about the detailed work I'm doing with policymakers at many different levels of scale and in different countries to use this model to tailor responses in specific places to real-world settings. The high-level general results come from a pretty extensive analysis of the full set of simulations. And what I'll be showing you on each slide when I talk about each high-level result is a single representative case, but of course, the results are not based on a single representative case. They're based on a detailed examination of these 3 million simulations that I talked about earlier. And there actually is an interactive dashboard which I will talk about at the end, where you can actually go through and have access to all 3 million simulations and explore policy formulations to your heart's content. So the first finding that I want to highlight here is, in our model anyway, true suppression is an attainable goal, not just flattening the curve by pushing cases out into the future, but really containing any little outbreaks that occur so that widespread COVID case spread is not happening, even with schools and workplaces open, if you use enough testing and contact tracing effectively. The second is that robustness is a really, really important aspect, and I think under-discussed aspect, given the uncertainty that we still face about so many things in COVID. And a primary goal of our model is to identify policies which are robust. And to help you see that a little bit, this somewhat busy diagram is showing actual simulation runs. Each dot is a simulation run, and it is showing the cumulative infections that occurred over the course of that run. And we're seeing actually 4 dimensions out of the probably 20 dimensions that we actually explored. But to help you visualize this a little bit, you'll see on the left, our left side, are different settings for the amount of contact tracing capacity, high, medium, and low, in each square box panel. And across the top are the columns represent different strategies for who you give tests to. Across the bottom are different levels of the amount of PCR tests per day that you have to administer. And on the right side are different adherence levels. And what you can see is that the set of policies that perform well when you have high adherence, lots of tests of high quality, and you use them effectively, there's very many policies that are interchangeable that produce low levels of cumulative infection, shown in light yellow colors. And when you have much less favorable conditions, there's a much smaller set of policies that are robust. Third point I want to make is that adherence is actually critical, and we actually highlight in our work the idea that making adherence possible and likely is a major policy goal all in itself that I don't think has gotten enough attention. In our model, if you can't get at least 3/4 of people who are asked to quarantine for 2 weeks to do so, you have almost no chance of containing the epidemic with any of the policies that we look at. And you have many more choices if you can get that up to 80% or 90% adherence. We find that if you have limited testing capacity, that testing people with symptoms is actually the wrong strategy. and that the most effective strategy of the ones we looked at is to assume that people with symptoms are at least likely to have COVID, to ask them to self-quarantine without testing them, just as we do for things like flu, where we ask people not to come to work if they feel sick, and to use all of the testing on contacts who are successfully traced of those symptomatics. And it turns out in our simulations that that does a whole lot better job of using the tests effectively. And finally, it's really important to wait for the moment to release social distancing and deploy something like test and trace. It won't work if background level of community spread is too high when you start doing it. I think I'll skip over serological tests for a minute, given the time constraints. This is a website that I think will also circulated. There's a main trace website, and then you can link to here this dashboard from that trace website. On the dashboard, you can dial in any policy combination of the ones we simulated that you like, and any kind of epidemiological scenario from the 16 very different scenarios, from very positive to very negative, that we simulated, and watch our projected curves for cumulative and ongoing infections redraw on the dashboard, and you'll actually see individual simulation trace lines, not just an average, so you can get a sense of the variability. And if there's time later, I'm happy to call that up on my shared screen and show it to you. In addition to these general results that we put out there on the website and in the forthcoming paper, we are working with specific settings, including at the state level, at the large organization level, at the international government level, to different nation states to take the trace model and apply it to specific contexts and explore specific policy suites that are being considered. And we are also working with partners in healthcare to think about, and in economics, to think about some of the downstream consequences that are not included in this version of the model that I showed you, and what complexities those introduce in the choice of policy that one makes. So I think I'm right on the half-hour mark. I will stop there and take any questions, and I have more details that I'm happy to go into. Let me stop sharing my screen.
Well, unfortunately, applause does not work well over Zoom, but
yeah,
I
no, that's
applause
okay.
on everyone's behalf. Thank you. That was a really fascinating project, and great to be having this conversation with you. We have a number of questions that are already in the chat. I encourage folks who have questions but haven't already dropped them in the chat to either do so or to use the raise hand function. I'll start off taking a couple of questions about sort of how the model works, and then we can maybe get into some more questions about the results. Guy
Sure.
Higgins from Boeing, did you want to ask your question?
So it appears that my experienced a higher infection rate and a higher death rate, bad outcome rate than minorities. But when we start looking at the data throughout the West, it also appears that for a number of different reasons, that those minorities are also in the lower socioeconomic strata, which result in being involved in a much more higher percentage in those essential businesses. So as delivery money, as healthcare workers and the janitorial workers and cleaning things. And so it appears that there is not that simple correlation between minority status and infection, but it's more a function of the opportunity for contact and infection. So does the model take care of that?
So yes and no. There's no direct representation in our model of what someone's employment is, what their job is, nor of their race or ethnicity. Those things are not represented in our model. The main demography that's represented is in age. But there is also, as part of the age heterogeneity, different representations of household composition. And one of the things that I think we've seen, at least in some minority populations, is greater spread because of greater intergenerational large household size, spanning many different age groups. And that sort of thing is represented in our model. What I would like to do, and that I was able to do 10 years ago when I was building models for the H1N1 flu pandemic, is to use very extensive synthetic populations that were developed by MIDAS that draw on all sorts of labor force data, demographic data, residential data, mobility data, both private sector and public sector, to build large virtual populations that were actually designed for this kind of model. But using them in an agent-based model requires access to computer power, quite substantial computer power, which I don't currently have, and so I did not go that route in the current work.
So I'd be remiss if I didn't note that we actually had a talk really diving into some of the mechanisms behind this phenomena just a few weeks ago. And Melanie Moses, who gave that talk, is on the call today. Melanie, I'm not sure if you want to add anything on this point before we move on.
Sure, I'd be happy to. Hi, Russ. Thanks for a fabulous talk. So I've been very interested. We sort of started looking into this early in the pandemic, what the rates of both infection and mortality are in minority populations. Particularly interesting in New Mexico, where the Native American population is just, was extremely hard hit, particularly initially, and African American populations. And a question that maybe a slightly different variant on what was just asked, which I think made some very good points, is whether the spatial segregation of people who are highly vulnerable in these professions that make them more exposed, perhaps have comorbidities or lack of access to healthcare that makes them more likely to die, is the spatial segregation of minority populations also a contributing factor? And it's something we do agent-based modeling inside the body rather than between bodies.
Yeah, sure.
And so I'm wondering if you have insights into that.
I think it almost certainly is a factor, but it's not a factor that this particular model looks at. But that there are other models that have looked at the impact of clustering of various kinds on the spread of epidemics, including residential segregation clustering.
Yeah, maybe just to follow up, we had a little bit of a discussion about this a couple of weeks ago. One question is whether, how much of the increased disparity can be attributed to that, right? I agree there has to be some, and how much of it is sort of correlative factors, that there are the socioeconomic factors that cause these comorbidities and these employment patterns and things are more intense in some places than others. And do you have any, so really the question is, how would one go about disentangling that or figuring out sort of whether there's a causal factor in the clustering that's dominating or some underlying features of particular places that's kind of dominating?
Sure. Well, again, this work that I'm presenting today does not delve into these questions and doesn't really address this in any substantive way, and wasn't designed to do so, but I do think they're very important questions, and I do think that this style of modeling can help shed light on them, and my inclination would be to do modeling like this that has a much richer set of demographic and residential characteristics using these synthetic populations, which do in fact have artificial agents who have a home address, and so you can look at segregation, that do in fact have an actual profession that's listed using occupational codes like you would use on your tax return. So we can say who's a delivery driver and who's telecommuting. All these kinds of things we're asking about would be possible in such a model if one has access to supercomputers, as we did 10 years ago. But the work I'm presenting today did not go into that space.
Okay, thank you. Thanks.
Continuing on with some of the methodological questions, Susan Fitzpatrick, you had a question about how agents were learning and the adaptability of agents.
Yeah, hi Ross, thank you for a terrific talk. Greetings from St. Louis. So yeah, what I was very interested in is whether your model could adapt as people's or individuals or the agents' behavioral change might occur as a result of their own experience, perhaps knowing somebody who had gotten COVID, or the result of information that's coming out. So particularly in the information you were giving us about adherence, that could vary, very dynamic over time. And I'm just wondering if your model accounts for that. Sorry.
I agree with you that it almost certainly is dynamic over time, and I have done some previous work on that kind of behavioral adaptation where people are specifically responding to a local signal of how much contagion is going on that's very myopic. And I think that actually that's one of the strengths of agent-based modeling, to be able to have endogenous behavioral adaptation. In this particular work, but given its focus on a very specific set of testing and contact tracing policies, I did not go into that, and adherence is assumed to be distributed at random across the population that I simulated, but a future version of the model could well go into those things.
Great, thank you.
But I think actually, from my perspective, that even before one worries about how to improve adherence, the very first thing is to put it on the policy radar as an important topic, and to point out that if adherence is too low, it sort of doesn't matter what you do, because it's not going to help. And so we have to first get enough attention to the question of adherence, and then I think actually the reasons for adherence are complicated and would take a fairly rich model to get right, but it's not out of the realm of possibility. And I think that this question is already on people's minds for vaccine, but strangely not for quarantine for some reason, even though in the countries where test and trace has actually worked, like Australia and South Korea and Germany and New Zealand and so on, there have been small outbreaks that have recurred, and they're almost always due to non-adherence with quarantine protocols. That's what drives them. So it already should be apparent that that's really important.
Great, thank you.
So I want to sort of pivot the discussion now, if I could, Ross, to some questions about the results of the model. Josh
Sure.
Jammer from ClearBridge, you had some questions about super spreaders and what that means in this context.
Yeah, Ross, first and foremost, thanks for a great conversation or great presentation. Just piecing together a couple of things that you said, and maybe trying to reading between the lines a little too much potentially, but it sounded like one of the key dimensions was using limited testing supply for the contacts of symptomatic patients. And you also mentioned at one point, I think, that most symptomatic people don't infect others. So is the efficacy there in terms of where the tests are applied being driven by the potential for those kind of, quote unquote, super spreader events? Is that kind of the key driver within the model, or are there other things going on kind of giving us that result?
That's a factor, but actually to defend against that being the only factor, because I think even though I'm more sure that that the fact that they're super spreaders and that there's a pretty non-even pattern of infectivity, I'm quite sure about that, as sure as one can be about anything in the data. But nonetheless, in case that's not right, or in case the distribution we used is not right, we did run versions of the model where we removed that, where there's no super spreading at all, and actually all of our core qualitative results hold, even in that case. So it's not only because of super spreading that prioritizing contacts rather than symptomatics is important. It has more to do with the importance of finding those contacts before they go on to spread disease, and the efficiency gain of simply asking people with symptoms to self-report symptoms to self-quarantine without you needing to test them first.
Awesome, thank you.
Catherine, did you have a question about robustness and sort of what we can actually get out of all of this in terms of an effective approach?
Oh, I do. Well, thanks. Thanks so much for this. It's really terrific. And I'm glad you focused so much on robustness. I have two questions that are kind of intertwined. One is I want to make sure I'm understanding the punchline. If we have sort of low to medium robustness across many, many different dimensions, can they ever add up to one? I guess is the essence of my first question. Or do you really need strong robustness on at least a few dimensions to get to a positive outcome? And then second, maybe more of a definitional question. I'm curious, given that you alluded to the potential, at least for testing, to maybe kind of make it up in volume, if the tests aren't 100% accurate, but maybe could be more prevalent. At what level are you measuring robustness, and how can we think about that across the different categories of examination?
Sure, those are both very good questions. So I'll actually take the second one first. Our definition of robustness here is what we do is we look at all the 3 million simulations, all the 10,000 or more different policy combinations across all the many different epidemiological scenarios, with multiple simulations at each intersection in that multidimensional space. And then we say we're going to compare each and every one to a baseline which is shelter in place continues indefinitely. And we're going to look for policies that do not involve shelter in place indefinitely, that have released at least some of the mass social distancing and replaced it with contact tracing and testing of some kind. And we want policies that do statistically indistinguishably as well as complete lockdown. So they're true substitutes for lockdown. That is, there's no more cases in the policy case than there would be at the baseline case of complete lockdown. And that's our definition. And we actually do identify, even in the very worst case scenario, a handful of policies that meet that definition, that do not involve complete closure of everything forever, that allow you to open lots of things and to substitute contact tracing and testing successfully. And then we also, that answers part of your first question is the set of things that are fully robust and empty set? No, there's actually quite a few things in there, and I don't think they're things which are out of reach at all for our country. They're fairly feasible things. And the second more nuanced point is, if you had some information that you weren't in the worst of worst case scenarios. So let's say we had 16 scenarios and there was, one is the worst case and 16 is the best case. What if I knew for sure we weren't in the top 5? That was better. We were better off than that. Then there's a whole much broader set of policies that also become viable in that same sense, that they do just as well as complete lockdown. And so part of the goal of models, in my view, is to help focus limited empirical energy in the right place. And so we're pointing out in our model what are the most important uncertainties to resolve quickly so as to expand the policy arsenal that's viable, is essentially the point. So
Cool.
And sort of maybe following up on something that Catherine mentioned briefly there, and is also a question that Laura mentioned in the chat, and was also a topic that came up in a presentation that we had at SFI about 2 weeks ago. There's been a lot of excitement about these sort of cheap litmus paper tests that use antigens, and you and I spoke briefly about this before the meeting started. Based on the results of your model, do you have any insights or thoughts on the efficacy of that as potentially one of these robust policy approaches?
Yeah, I mean, I think there's a substitution curve at which you can substitute volume of tests for accuracy of tests. So a very large number of not very accurate tests can substitute for a much smaller number of much more accurate tests. And what exactly the shape of that curve is something, at least in our simulated world, that we estimate and we can speak to in these results. I think in general that that is a trade-off that is worth considering, especially given the speed question, which is in a sense the third dimension. And I think what's abundantly clear is that tests that take 2 weeks to return a result are useless. By and large, because during those 2 weeks you've already done whatever spread you're going to do if it's positive. So.
And does your model incorporate those time lags? Is that a parameter that you?
We have some of that, but not as wide a range as other things. Yeah.
Okay. Stephanie, did you have a question?
So I guess just to be clear, what I'm saying is that I think that the excitement over the new litmus tests and the antigen tests and so on is, from my perspective, the idea that you can substitute volume and inexpensive volume for accuracy is not a new idea or a particularly surprising one. The more exciting piece is that these are more rapid tests, and both because the actual processing is more rapid and the supplies needed are more are cheaper, and also because that means that you can do the processing of the test closer to where you administered it without having to ship them to central processing areas, so that, like, for example, a university could do its own testing right there on campus, which is probably the only way to safely reopen universities. So.
And this is admittedly far more your world than mine, but I guess my understanding was that it wasn't so much that this is exciting from an intellectual point of view, but that many of the regulatory agencies had not been on board with this sort of philosophy as recently as like 2 or 3 weeks ago. And I don't know if you know more about that than I, or is that a mischaracterization?
Yeah. I mean, that's true. Although I think it's sometimes easy to lose sight of what is happening with federal agencies in this, because they've been sort of absent from leading the policy discussion, and it's mostly devolved to states and counties and cities to make these decisions. So.
but not with respect to what types of tests could be, say, from an FDA perspective, there's certainly
Oh, sure.
limitations that they can control what these smaller
Sure.
localities can do.
Yes, indeed. Yeah.
Okay, Stephanie, did you want to jump in with a few questions?
Yeah, thanks, Ross. That was fantastic work. It's a pretty simple question, but your model, like a lot of SIR models, starts with one population and looks at what happens over the course of time. As we've seen in New Mexico, we've gone into quarantine from outsiders because we had people coming in who were bringing it to essentially an islanded population. From your model, do you have any insights on what would happen if we had new recruitment of the disease from immigrants coming in?
Great question. Yes, we did think of that possibility and do our best to include it while stopping short of a true multi-patch or multi-site model. So what we do is we vary the amount of initial infected people at time zero that are present across different simulations. And so a high number of initial infected people at time zero, it mimics the idea that you had a previously well-controlled situation and then you're importing new infections. And that initial infected percent can be as high as 1% of the population. And I think it's probably not feasible that more than 1% of a population's worth of new infections in a single day are imported anywhere into any state in the US where there's a well-controlled epidemic at the moment. But so that was our attempt to address that.
Great, thank you.
Susan, did you want to jump back in with a question about using this model to think about the implications for vaccines and the adoption rates of vaccines?
Sure. Thank you. Yeah, I'm just, when you brought it up, Ross, in your comment, we were talking about adherence earlier, that while most people have been thinking about this from the sense of quarantine, so we've been very interested in trying to get ahead of, if we do have a vaccine, how we're going to increase or get reliable vaccine uptake. And so I was just wondering if you or your collaborators are looking at the kinds of policies that could increase vaccine uptake. I think we're going to get one shot at this, and I think the messaging is going to be really important. And the more
I agree. I agree with you. That's a hugely important piece, and that is the next phase we need to be really thinking about. That is not something this particular modeling has looked at yet, but the framework we built would be a way you could do that. I basically built this whole model that I've shown you so far on some initial seed funding, and which has run out. So I'm running around trying to fundraise to keep going, to answer questions about vaccine, to answer questions about preparedness for next time, and to answer questions about very different settings, like in the developing world, where there's a whole quite different situation emerging. But I agree entirely, that's important.
So Ross, I don't want to put you on the spot here, but sort of as we're getting ready to close this out, one of the things that you see a lot of discussion of in the media is comparing the strategies of different countries, different states, based on your experimentations with this virtual lab. Are there any sort of suites or sets of policies that have actually been implemented that you would hold out as an exemplar of sort of the insights that you've learned working with your model?
Yeah, I mean, I'll just give you some data that's instructive, I think. So I'm here in the state of Maryland, which has more testing than most states in the US, especially because our governor was able to get a lot of testing materials from Korea. And so Maryland is actually doing daily testing of about 4 in 1,000 people. Which happens to be the rate that we actually show in our model is where you need to get to have successful control over an epidemic. By comparison, let's say Kansas is doing about 0.8 per 1,000 people, so far lower rate. But it's also interesting that it really does matter how you use the tests, because Germany, for example, is testing 1.8 per 1,000 people, but keeping very good control of their epidemic. And South Korea maxed out at testing 0.3 people per 1,000, so much less than Kansas is doing, and still was able to control their epidemic to a large extent. So it matters how many tests you have, it matters how you use them, it matters how accurate they are. All these multidimensional things matter, and it's what that multidimensional surface looks like that's really important, which is really the reason for TRACE to exist in the first place.
you know, as you played within Trace with all of the different assumptions that you can make to operationalize the model, were there any really surprising scenarios that played out? Like one of the benefits that we often think of for agent-based models is the opportunity to do these scenario planning exercises. Was there anything that really surprised you that didn't seem intuitive at all, but was sort of a new insight that you got?
Yeah, I mean, I would say that some of the, certainly this idea of what is the right way to use limited testing was a deeper rabbit hole than I expected it to be. And we did lots of different variations there, some of which we expected to work well and didn't work well, and some of which we were surprised worked as well as they did. So that's a particularly rich part of the space. The question of adherence, I think I was pretty surprised at just how sharp the fall off is once in success rates, once adherence gets below a certain level. And then I think echoing what many other people have said, that actually closing schools does something toward containment of COVID, but it's not actually as heavy hitting as many of the other things that one might do. And it's pretty easy to substitute in enough testing that you don't have to keep schools closed. And in the current national hand-wringing about school closure, I think it's, quite striking how disconnected that seems to be from the discussion about testing, when in fact they're deeply interconnected. And places that have been able to reopen their schools in Europe do so with lots of testing, and then you can substitute testing for mass social distancing, including school closure. And it's a shame that we haven't managed to connect that up here, by and large.
At the risk of putting you on the spot there, do you think that we have enough testing accessible in the US to safely open schools at this time?
Well, the problem is that the US is not a monolith. It's a deeply heterogeneous place right now, and without a coherent federal strategy. You're seeing not only different states, but different counties and even different school districts making totally wildly different decisions and having different access to different amounts of resources. So there's hard to talk generally about what the US, quote unquote, should do. And I think, the difficult part becomes that if you're asking a small school district in the Midwest to compete on the global market with the nation state of Germany or New Zealand for testing supplies, they don't have the international logistics and the buying power to do that in the way that a US federal government would, for example.
Of course. So I know that we're getting near the end of our time. I just want to pause for a minute and see if there are any other questions that anyone would like to raise.
Could I ask a question? Ross, this is awesome. This is really great work. I was wondering, you mentioned that there is too little discussion about how to ensure economic circumstances and incentives for people to actually stay home, to enable them to stay home. So I'm wondering, how easy or difficult it would be to connect your model with some economic calculation? So what would it cost to continue paying some compensation to people so that they can stay home in different states, depending on different average wages and so on? Or did you have such discussion with economists, perhaps?
I've looked at that part is not in the model yet. I agree that it would be a really interesting and fecund part to put in the model, and I think it's really important to ask those questions and put dollar signs on that, because I'd be willing to bet that the amount it would cost to do that successfully is much smaller than the amount of cost we're incurring by not doing that, by not controlling COVID well. But I haven't looked at it specifically. I have thought about how I would go about that, though, and I do think that it's ultimately the point of all of these things, closing workplaces and closing businesses and using testing and using contact tracing, the point of all of it is to get people to not have contact with others. And if they don't adhere to that, then none of those policies work. It doesn't work, right? So that's actually sort of a fundamental thing you have to get right. And I just don't think it's been enough part of the discussion. So.
Great, thank you.
Yeah. Melanie, did you have a question?
Yeah, I think your point about testing, being sort of the answer to how you get through this without massive shutdowns is really interesting. And I'm wondering, back on these sort of cheap, possibly less accurate testing in that landscape, what's the role of that the decision being sort of democratized, right? The decision about when to test and how much to spend on testing, going to individuals potentially, you know, in the ultimate scenario where you can, you know, go to Walmart and buy a bunch of tests that you can use at home, test yourself or test anyone who's coming into your house, those sorts of ideas. It seems to me that, you know, one of the problems with testing is that the places that need testing most have, you know, in that moment, the greatest testing delays, right? It takes a long time to get it, it's expensive, you don't know, right? So has there been any work, is there any sort of social science even that would suggest whether that in of itself, like sort of empowering local people who have the, you know, right there, they're in a situation, they know how vulnerable they are, or they know how much is in their community immediately from news reports. Does that help to distribute the tests to where they are most needed and most effective? Or is, you know, is there any research on just that concept?
I haven't looked at that specific question in this model. We did do some work at Midas during the last pandemic when there was discussion about how to use antiviral drugs, which were also in limited supply. And there was a real policy proposal to take the entire US federal government stockpile of antiviral drugs and let the market decide allocation. I think that was shown to be a really bad idea for lots of reasons. And it was clear that or socially desirable distribution. So I'm in general leery of the idea that you should just completely decentralize and let essentially market forces or local information decide because of how interconnected epidemics are. But I do take your point that there are some real equity considerations that have to go into the distribution of where testing supplies go as well.
Yeah, thanks. That's a really, it seems like that I could see how it could go either way, right? So it seems like a great sort of things to test in this kind of, you know, modeling laboratory to find out, is there a tipping point?
I agree.
Yeah, nice, thank you.
Yep.
So we're just about at time. I want to thank you again, Ross, for taking the time to spend with us and have this discussion. Again, there's no good way to applaud on Zoom, but I will use the applaud reaction and encourage other people to do so as well.
Okay, very good.
You know, as we sort of look forward for the rest of the month, Casey, are there any other action meetings coming up that folks should keep in mind?
Yeah, so our next meeting will be on emergent engineering. We're trying something a little different, and we'll spend most of the time in discussion using an article that SFI professors Jessica Flack and Melanie Mitchell recently published as a jumping off point. And Kayla will drop that article in chat. She just did. Jessica and Melanie will participate in the meeting, and we are reaching out to David Krakauer and a few other researchers as well. The meeting will take place on Thursday, September 24th at 10 a.m. US Mountain Time. And we'll send more details to Action members later this week. And as always, feel free to contact me directly or email action@santafe.edu if you have any questions.
Awesome. Thank you, Casey. Ross, thank you again for doing this. And thanks to everyone for joining us today.